At this year's ACC Annual Scientific Sessions, there are 24 abstracts being presented based on NCDR data. We are here to talk about a late-breaking clinical trial, the relationship between procedure volume and outcome for transcatheter aortic valve replacement in the U.S., clinical practice, insights from the STS-ACC TVT registry, obviously. So I want to introduce to you John Caroll, who is an MD and professor of medicine and specifically cardiology, director of interventional cardiology, and the co-director of the Cardiac and Vascular Center at the University of Colorado. First, some background. Why did you want to do this study?
Well, the volume-outcome relationship is an important thing to study because it potentially is a determinant of an outcome of a procedure or an operation. And transcatheter aortic valve replacement being relatively new and having a major impact on how patients with aortic stenosis are treated, it becomes important to study whether there is a volume-outcome relationship and separating it from the other determinants of patient outcomes.
Because it's really a requirement to report to the NCDR. For most people in the United States, you have a good database to choose from here.
We have an excellent database because, first of all, the number of TAVR sites was limited in the United States by the national coverage decision that laid out some specific requirements of institutions, that is hospitals who wanted to start programs, and operators for that matter. So already it was a smaller group than doing, say, surgical AVR in the United States. But yes, part of the importance of the TVT registry is that it did allow the gathering of the entire commercial experience in the United States with TAVR in order to answer a variety of questions, one of which is whether outcomes had an association with the volume of procedures performed. And that's why this study was organized and done with myself and multiple people, including the Duke Clinical Research Group and my co-authors, many of whom are also on the steering committee of the TVT registry.
So how many people did you look at and what did you find?
So we looked at a rather comprehensive period of time from day one of TAVR commercial introduction in the United States up until November of 2015. And so that involved data from 395 sites and over 43,000 patients who had undergone TAVR.
Wow, that's an impressive number.
It is, but it's an important, robust number to do such an analysis, which is complex.
Right. So what did you find?
So first of all, the methodology, we had to break up how do you stratify volume. And so we used the case sequence method where the first case from each place determined that first case sequence and all the way down. And of course there's a huge spectrum of volume being performed out there at the different sites. So as you get up to the higher and higher numbers, there are fewer institutions represented, but with 43,000 patients, you have quite a data set. Yeah. Then we had to decide on what outcomes to look at, and we chose mortality, bleeding complications, vascular complications, and stroke. And all of those had to be risk adjusted because a major determinant of outcomes are patient characteristics, as well as what technology they received. And for that, we used the surrogate of time from November 2011 until now to adjust for that other impact on outcomes. So what did we find? We found that volume and outcome are associated in a rather strong way, both statistically and clinically. That is, the greater the volume, the better the outcomes, risk-adjusted mortality rates, risk-adjusted bleeding rates fall. And that's an interesting curve in that in the first 100 cases we see a rather steep slope, which is the traditional learning curve. And then rather than leveling off, we saw the curve continued. That is, at higher and higher volumes, outcomes became better and better. And that there's an important message there that we think is separate from different risk patients being treated, different from evolution of the technology, but was as these programs grew and they got better, that translated to better outcomes for our patients.
Were you able to analyze by access point?
Yes, and that analysis is ongoing. First of all, we really wanted to do a comprehensive look, not doing subgroup analysis, because for a particular center, for a particular patient, it is what it is, and you will want to see whether the volume-outcome relationship exists like that. But we also, at this point, have looking at transfemoral, where we did see a volume-outcome relationship, particularly in the bleeding and the vascular complications, not in overall risk-adjusted mortality. And also in the overall cohort, we didn't see a volume outcome relationship for stroke. But the stroke rate within the registry was only around 2%, so hard to see much of an impact on that variable.
So what's the take-home message? What can we learn from this?
Well, this was a unique rollout of a new therapy. It was highly controlled. It was all hands on deck, from FDA, from CMS and the National Coverage Decision, from professional societies giving guidance, and from industry in terms of intensive training programs and help during the procedure, proctors and very expert clinical support staff. And so the take-home lesson is that there is an impact on volume, on outcomes in this important procedure in the first 4 years of the clinical experience. And that's important to know that. And it doesn't mean low volume centers are necessarily bad. They may be continuing to develop. And certainly within low and high volume centers, you see a spectrum of actual outcomes. Secondly, it's not the only determinant of how we should organize our medical system. We need access. Patients need access to these new therapies. And certainly with now approximately 430 TAVR sites in the United States, not many patients are far from multiple TAVR sites, and that's good because the therapy needs to be accessible. So these are the data. We want the discussion about the analytic methodology, et cetera, but for now other people whether in CMS, professional societies, to incorporate this into how they think this therapy should be optimally structured and offered in the United States. But this provides robust, objective data that heretofore we just didn't have.
Yeah. And it's a late-breaking clinical trial here at the SCC 16, so congratulations.
Thank you.
Appreciate that. And as I said, there's a variety of NCDR papers being presented here. Please look at CardioSource World News and CardioSource World News Interventions, where we'll summarize some of those. I'm the executive editor, Rick McGuire.